Get started in a minute, Peter. I'll be introducing you in a minute. People that join at the very last minute, just so you know.
Oh yeah, it's the same thing everywhere.
So good afternoon, everyone, and welcome to Medical Grand Rounds. Before I introduce our speaker, just a reminder to please enter your questions in the chat at the end of the presentation, and please answer a brief survey that will be sent to you immediately after the rounds that will let us know that you were present today. Our speaker today comes courtesy of the Department of Oncology. Our speaker is a surgical speaker, which is a little different for us, but it's a great pleasure to introduce to you Dr. Peter Metrakos, known to many of you. He's a professor of surgery, pathology, anatomy, molecular biology at McGill. He's director of the liver transplant program at the MUHC and director of hepatic, pancreatic, biliary surgery and the fellowship program at the MUHC, and he's the leader of the cancer research program at the RI at the MUHC. Dr. Metrakos graduated in general surgery at McGill and then completed a basic science fellowship in the Department of Experimental Surgery, focusing on physiology of the pancreas and cellular transplantation. Additional fellowships were carried out in London, Ontario, and in Minnesota, which included whole organ, pancreas, and islet cell transplantation. His research interests include basic, translational, and clinical research. Research includes the role and interaction of chemotherapy and liver resection in the management of liver malignancies. He's one of the founding members of the Liver Metastasis Research Network, with a worldwide membership that focuses on study of colon cancer liver metastasis. His overriding theme of work is systems medicine and personalized care of our patients. This had led to numerous collaborations. Clinically, Dr. Metrakos runs a high-volume hepato-pancreatobiliary and transplant surgery service. He has a high-volume complex liver surgery practice, as well as directing one of 18 accredited HPV fellowship programs in North America. And finally, his clinical interests are in colon cancer, liver metastasis, primary liver cancers, fatty liver disease, precision oncology, and further and more. So I will stop there, and it's a great pleasure to have Dr. Metrakos with us today. Peter, the floor is yours.
Thank you, Nadia. Thank you everybody for having me. It's a topic that I like to talk about, so I don't really have a problem when I get invited to talk about this. So I full disclosure, I'm a transplant surgeon by training. So I kind of learned oncology on the job, and I credit, there's some people that I need to credit as Adrian Langleben was first. He was an oncologist at the Royal Vic, but he's now at the St. Mary's. And he was the one who kind of first said to me, maybe you could do surgical oncology. And I kind of thought that was an oxymoron, and I told him so. And he says no, and he proceeded to explain to me how a surgical oncologist can work and how you interact. Michael Thurwell also was there at the beginning, and was quite adventurous with some of the things that we got involved in together. Following that, Yogesh Patel, who was director of endocrinology, because of his involvement with somatostatin and somatostatin receptors, he had a very large volume of neuroendocrine tumor patients that he followed. And he introduced me to neuroendocrine tumors and introduced me to the world of neuroendocrine tumors, including the pharmacological companies that were involved in this, in developing treatments for this, and other societies that were involved in this. And to this day, it's been one of my sort of niches. And then Peter Kavan, we had a very long working relationship when he was at the Vic. He's now at the Jewish. and more recently, Jamel Asala. So these are the people who've educated me in oncology because I didn't have my own sort of formal education. And it's been a good ride, and the management of this type of liver metastasis has evolved greatly since I begun. So it's a common cancer, therefore it's important. It's also lethal. It's the second most lethal after lung cancer. And liver is the most common site of metastasis. And you can see the burden that we have in Canada. I have the numbers from 2019, over 26,000 cases and nearly 10,000 deaths as a result. So initially, we had basically, for non-resectable disease, we had 5-FU leucovorin, which really did very little. Response rates were maybe 5% or under. Really, in the late 1990s, early 2000s, we began to get some drugs that actually worked. It was irinotecan, oxaliplatin. So the regimes that you may have heard of are FOLFIRI and FOLFOX. And then came, in the mid 2000s, came the targeted therapies. Bev, or Avastin, as most people would know it, was an anti-VEGF, so it was targeting angiogenesis, and there was great hope for that. And unfortunately, we had mixed results. There were some good responses, but not all. And I'm going to explain that situation, and that's partly, it's a lot of the work that I do now it revolves around that. And then we also had cetuximab, or anti-EGRF therapy for KRAS wild-type patients. And then we had, small molecules that were TKIs that were basically also anti-angiogenic. The concepts that evolved over this time, palliative chemotherapy, giving patients that are unresectable, palliative chemotherapy to extend their lives. Adjuvant, which is, after you resect people, to give chemotherapy to them to improve their outcomes. And of course, neoadjuvant, which only became something in the 2000s when we got the better drugs, because we were always trying to downsize people, get their tumors smaller so that we can provide a resection. Because resection to this day is the only way really to cure, except for a small group of patients that I will mention. This is a newer slide. I put it up because at the end here in the later here are the immunotherapies. And immunotherapies in colon cancer really only are right now for microsatellite instability patients, MSI high patients. And they used to be the worst prognosis, and now it's almost like a lottery ticket. It's only 3 or 4% of these patients, but immunotherapy, I think, may be able to provide even cures in some of these patients alone. So that's where we are now in terms of our therapeutics. In terms of overall survival, it really has been incremental. So you can see, from the days of just 5-FU, with around 12.6 months median overall survival. We've now come to about 24 to 28 months. If you look at all these regimes that are coming on, they all kind of give, oxaliplatin and irinotecan are in there in most cases. And then towards the latter years here, you add the Avastin and the cetuximab for targeted therapies in combination. And of course, we sequence these regimes to try to get the best results we can. If you want to know the natural history of this disease, you have to go back and look at series of patients from the late 70s when liver resection was starting to happen, but still there was a pretty high perioperative mortality and a pretty high morbidity. But you can see here clearly that if you did not get a liver resection, you did not survive. No one survived to 5 years. If you got a liver resection, roughly 25% were alive at 5 years, and they were all disease-free, meaning cured. And the truth is, although we're getting up to 50% 5-year survival, 60% 5-year survival today in resectable patients, most of the, anybody over the 25% in your case series is really alive with disease. So that 25% disease-free has not changed since the 70s when resection was starting to happen. So early on, I really realized that the amount of disease wasn't everything. And this gentleman was in his 50s. You can see he has an excellent liver, reddish brown, with sharp edges. Unfortunately, he had a 3.5 centimeter liver metastasis under the left lateral liver. And it's not really one of our bigger resections. Actually, it's one of our smaller resections. But even though he had a small amount of disease, one lesion, the CEA, which is a tumor marker, wasn't extremely high. He unfortunately passed away within about a year and a half with widespread metastasis, including peritoneum. Compare and contrast this with this 40-year-old female. I remember her age because I was 40 years old when I resected this lady. You can see that there is probably several lesions that have come together to form this very large lesion occupying the right liver and part of the left liver, segment 4, encroaching on the left portal vein. And if you were able to scroll this screen, you'd see that it was encroaching on the left hepatic vein. We were able to resect her. It was a very large resection with some vascular reconstruction. And this is what it looked like after. So you can see that segment 2-3 here has grown tremendously to compensate, as well as segment 1. And you can see how we had to strip the liver off the left portal vein here to get the tumor off completely. So I say compare and contrast because I lost her to follow-up 8 years after this operation, disease-free. So clearly, in my mind, and other people's were noticing this, that the amount of disease wasn't everything there was to it, but there was other factors playing into whether a patient survives or not after resection. So I've listed a bunch of a series of different patients that have been published that were resected. And you can see now, I know they're in the 2000s, but if you update this list, the results will be very similar. You can see that we go from about 35% 5-year survival to about 60% 5-year survival. It all depends on patient selection, of course. But the overall result, the overall 5-year survival is around 40%. But still, only 25% of them are disease-free at 5 years. So the rest will pass away from the disease, but because they got a resection and we have modern chemotherapy, together we get more people to 5 years. If you don't provide a resection and only give chemotherapy, you don't get them to 5 years. So because of this idea that we can provide longevity and possibility of a cure with resection, we changed what the old criteria was, which was based on what was removed in terms of determining if we can resect or not. What I mean by that, it was all about the cancer. So number of metastases, the size of metastasis, was the disease bilateral. And of course, extrahepatic disease was a contraindication to consider resection. And as it evolved, we now decide on whether we can resect or not by what's left behind. So we need to be able to perform what we call an R0 resection, meaning remove all the tumor. And we have to have an adequate future liver remnant. In other words, the liver that we leave behind immediately has to support life until the liver regenerates. And we need one bile duct left behind, one portal vein, and one hepatic vein. So during that time, as the new chemotherapies came up, I'm going to put one or two publications up that we put up, but there was a lot of activity in this area that our group did. But here I'm showing sort of the response to chemotherapy as sort of a biomarker. So what we did here, and it was Gabriel Chan was one of our residents at the time here, and he's now a hepatobiliary surgeon and kidney surgeon at Maisonneuve-Rosemont Hospital. He looked at 50 very advanced patients. So in other words, they had positive lymph nodes in their primary, synchronous liver mets, lung metastases that we also resect, of course, multiple liver lesions, bilobar, and a high clinical risk score. And they were given 6 cycles of neoadjuvant chemotherapy, either FOLFIRI or FOLFOX, really. And we had Vicky Marcus, one of our pathologists here, grade the tumors after the resection. And we graded them into a pathological response grade 1, 2, or 3. 1 being the poorest response with more than 10% viable tumor, and 2 less than 10% viable tumor, and 3 absence of viable tumor. When we grouped 2 and 3 together as a strong response, and we looked at overall survival, you can see there was a significant difference between overall survival of the strong responders versus the weak responders. And then if you look at progression-free survival, again, there was a very strong difference between the two, depending on whether they had a strong response or a weak response to chemo. So this actually, to this day, we use chemotherapy in patients with a lot of disease to determine whether we should approach them and resect them. If they get a very good response, then we have more initiative. We feel that more justified in trying to resect them. So following those days, Penino Brat from the Liver Metastasis Research Laboratory approached me that there was a small group together at that time, probably around 10 years ago, that was interested in liver metastasis and invited me to join. And then that group has grown tremendously over the last 10 years. You can see we're located in many different countries, universities, and the McGill group from the MUHC's, Penino Brat, Julia Bernier, Miguel Bernier's lab, my lab, and Peter Siegel labs from the Goodman Center, a very long-time collaborator of mine. And we have meetings annually at different sites, different membership sites. And one of the things that's come out of this group is that one of the group members from Antwerp, I'll show you his work in a little bit, Peter Vermeulen, is a pathologist, published a small paper in a pathology journal in the early 2000s that looked at growth patterns in liver metastasis, and he established 3 growth patterns. And Andrew Reynolds, which you can see here, and myself co-led an investigation into these growth patterns to see why anti-angiogenic therapy wasn't living up to its potential. And because we felt that all tumors were angiogenically driven. And what we elucidated from these growth patterns, and you'll see that in a minute, is that not all liver metastases are driven by angiogenesis, but some get their blood supply from what we call vessel co-option. And this led to, I think, it's becoming recognized that this is kind of sort of groundbreaking in terms of how we approach tumor vascularity. And the first authors were Sophia, who was a PhD student with Andy. She's in Melbourne, Australia now, practicing oncology. And Ev Semino was my PhD student, who is now an HPB liver transplant surgeon at the SHUM. So this is Peter Vermeulen, the pathologist that I was talking about. So there are three histological growth patterns that Peter described, and we further elucidated now. The desmoplastic lesion, which the cancer cells never meet the hepatocytes because there's a desmoplastic layer between them. The pushing lesion, and you'll see that we've kind of defined that the desmoplastic lesions are angiogenically driven in roughly 40% of all the metastasis. Pushing lesions are the cancer cells and the hepatocytes meet, and the cancer cells push on the hepatocytes, but they do not invade the hepatic plates. And this lesion is less frequent than the other two, and the least understood. Maybe it's a transition lesion from one to the other, but we're not quite sure yet. Replacement lesions are the cancer cells invade the hepatic plates and surround the sinusoids and co-opt existing mature vasculature, thus vessel co-option. And that's the way they get their blood supply. And they're roughly around 40% of metastasis. And there's in between where they're mixed with all three types of lesions together. So what we did in this work was we took patients that had been treated with chemotherapy and Avastin, anti-VEGF, so an anti-angiogenic, and at least 6 cycles. And then they were resected. And then we had our pathologists score them for histological growth pattern. In other words, were they replacement or desmoplastic, and pathological response. How well did the chemo destroy the tumor? So good pathological response had less than 25% viable tumor in the lesions. And you can see that good pathological response is enriched with desmoplastic lesions, the blue. The poor pathological response, you can see, is enriched with red, which is a replacement lesion or the vessel co-opting lesions. So clearly, if you've given anti-VEGF with the chemotherapy, you get a better pathological response in the desmoplastic lesion, not as good in the vessel co-opting lesion. And this was verified by a second cohort of patients from the Royal Marsden Hospital in London, England. Then we looked at overall survival of these patients. And you can see that if you were an angiogenic or desmoplastic lesion and received anti-VEGF plus chemotherapy, and you got resected, you had a 50% 5-year survival versus an 18% 5-year survival if you received the same treatment, but were vessel co-opting lesion. Quite a difference. Seeing spreads like this on curves is not usual. Then we looked at a group of patients that received chemo only, no anti-VEGF therapy. And you could see that the benefit that desmoplastic lesion received disappeared. And in fact, the VEGF, if you look at the red line, the replacement lesion, the VEGF may be detrimental if we give it to vessel co-opting or replacement lesions. So I think it probably becomes quite important to be able to identify these lesions before you start treatment. Then our group, led by Fula Lazarus, and I'll show you a picture of her in a little bit, but we looked a little deeper into it to confirm that these lesions were angiogenic. And I'm just gonna, I just want to point out the top panels in this slide. So this is a desmoplastic lesion. You can see, it's a photomicrograph, obviously. And you can see the desmoplastic ring. This is the cancer side, and this is the normal liver. You can see the sinusoids that are present in the liver. They're not present in the cancer. And because this is angiogenically driven, and we have stains that tell us that these are immature blood vessels. Whereas in the replacement lesion, you can see there's the cancer and there's the liver. And you can see how it kind of blends in and how the cancer seems to be taking over these sinusoids as it progresses. So clearly, vessel co-opting and angiogenesis. The other thing that's going to become important as we continue our talk is that that we believe that at the end of the day, in unresectable cases, as you continue to treat and you develop resistance, that everything turns into a replacement lesion. Everything goes vessel co-opting, and that's the mechanism of resistance that is deployed by the cancer to escape our treatments. And you could see this. This is a desmoplastic lesion here that's been treated with Avastin and chemotherapy. You could see that it's necrotic in the center. But if we were to show you a high power magnification of this lesion, you'll see that there's a ring of viable cells along the desmoplastic ring. And then as you continue to treat and resistance develops, these buds of tumor come out from the desmoplastic ring. And if you look at them closely, they are of replacement type of lesion, a vessel co-opting lesion. So this is evidence that everything at the end turns into a desmoplastic lesion. It'll become important as I try to tie things in with immunotherapy and the immune landscape of these lesions as we move forward here. So after that work was published, then others came out and looked at their work and kind of confirmed the desmoplastic lesion. This was some of the best ones that have come out. Comes from Keys. We call him the world's tallest surgeon. He's my counterpart in Rotterdam, and he's about 6'8". Has to bend over to go through a normal door, but he's put down some excellent work and really confirms what we were saying on the clinical outcome side of things. Here, I'm not going to go through this, but I've just listed all the better outcomes that you see if you're a desmoplastic angiogenic lesion versus a replacement vessel co-option lesion. Things like increased overall survival, good response to neoadjuvant, lower rates of recurrence, and so on. And we've looked at our largest series of patients. Lucina, who's doing our PhD, she's a surgical resident from Loma Linda in California. She's here with us doing her PhD, and she's looked at our data. She looked at 352 patients that we've biobanked. And this is Stephanie. She started the liver disease biobank with us and really runs it. And it's really our lifeline. This is the way we do our work, is we're using these samples. So she's very important to us. So after excluding some of the cases because of a variety of reasons, 283 cases were analyzed. And you can see that whether they receive chemo or don't receive chemo, if they get resected, the overall survival is really dictated by whether they're desmoplastic or replacement, as you can see here. And then if you look at the chemo-naive patients, meaning patients that have just been resected, not received any chemo, you can see that you get 80% 5-year survival or more with the desmoplastic lesions. I don't know that you can do anything better if you give these patients chemo. So I think it's a really good biomarker for outcomes. So once we've done all this and we looked at all this, we several opportunities obviously present to us. So the first is that obviously there's a need to develop methods to determine the growth pattern prior to resection, and if the patient's unresectable, so that we can actually choose the right therapy. So obviously imaging and the use of artificial intelligence with imaging might be one way to go. And the other way is to look at liquid biopsies and look at cell-free DNA and maybe looking at the cargo of extracellular vesicles. The other opportunity is to determine the molecular mechanism or mechanisms of vessel co-option, so that maybe we can convert co-opting lesions into angiogenic lesions, since angiogenic lesions seem to be able to convert to vessel co-opting. If we can convert them back to angiogenic lesions, then maybe we can target them with the therapies that we have now for angiogenic lesions. And also, if we have the mechanism laid out, we can actually figure out if we can target the actual vessel co-opting tumors themselves. So we have worked on the imaging part, and we can tell in some cases, maybe 40–50% of the time, we can actually tell what type of lesion it is. We have these features that we figured out by looking at MRIs plus resected specimens, and it hasn't been published as yet. But I think that there are, within our research network, there are groups that are looking at this with artificial intelligence, looking at pixels and renderings of these tumors, and we're contributing to that. And hopefully that will become even more precise as we move along. In terms of looking at liquid biopsy type approaches, one of the things that we've looked at with Peter Siegel from the Goodman Center and Sebastian, his research associate with our group, is Claudin-2, which is Peter's favorite molecule. And we had published some work with Peter many years ago on Claudin-2 in breast cancer liver metastasis. And now, we didn't know that then, but now we know that breast cancer liver metastasis are almost uniformly vessel co-opting lesions. So we thought that maybe Claudin-2 could be used as a biomarker. And in fact, it does look like, if we look at the Claudin-2 found in extracellular vesicles that we isolated from the plasma in these patients, that it is elevated compared to desmoplastic lesions. And we validated this with a European cohort from Rotterdam, and it seems to hold water. So this may be one vehicle that we can use to tell us a difference. Now, what we've with Anthula, who's basically has been with me for 10–12 years, and is an extremely VIP person in my laboratory. We put together a MedTech grant using artificial intelligence. We teamed up with a company called MIMS, a startup here in Quebec, and we looked at 100 patients, and we looked at cell-free DNA, extracellular vesicles and their protein signatures, and also the RNA sequencing and DNA sequencing of the tumors that we resected. And MIMS is applying AI to this and trying to come up with a variety of signatures. The work's been completed. There's a few more things in terms of data that needs to be added. And there is a sort of panel that's been created, and a website has been created. And the data is going to be analyzed soon, and we're hoping for some signatures that will help us move forward on this. It's been quite an experience learning a little bit of how AI works and how to incorporate multiple different data points to get somewhere. The one thing that we're doing in parallel with this is looking at the proteome of extracellular vesicles that we have analyzed. So basically, we've developed and validated a technique for isolating extracellular vesicles from blood and characterizing them using a variety of instruments, which I'm not going to get into. And then we pass them through mass spec to get protein signatures. And that has been led by Migmar, who's a PhD candidate in our laboratory. And here's a volcano plot that she's created using the mass spec data. And we've definitely identified proteins that are unique to each type of lesion, and maybe one particular protein that's quite unique and kind of fits in with where we're going with some of the immunology. It seems to be a protein associated with macrophages. So, and you'll see why we think that's relevant in a few slides. So along with, as we're doing all this, we developed a theoretical model so that we can actually, kind of use it as a checklist as we start to develop the mechanism for vessel cooption. So the theoretical model looks at the conditions that would favor vessel cooption. And so basically, after the metastatic cascade occurs and you have now cancer cells in the liver, we absolutely know that if the highly motile cancer cells develop vessel cooption, and the less motile or motile deficient cancer cells grow by angiogenesis. And we know this because we have knocked down the motility from highly motile cancer cells, and they convert from vessel cooption to angiogenesis. So if you have a motile cell, it'll interact with a variety of components in the tumor microenvironment, which includes hepatocytes. And if you remember, the hepatocytes have to move out of the way in order for the cancer cells to vessel co-opt. So how do they do that? I mean, they could physically move them out of the way. There could be apoptosis of these cells, necrosis, autophagy, or they could be transformed, EMT, so they become more motile and move out of the way themselves. Also, the vasculature that's going to be co-opted needs to maintain its integrity and its maturity. Otherwise, the cancer cells will not be able to co-opt it. In angiogenesis, the reverse happens. When there's angiogenic stimuli, there's a breakdown of vessels so that there's sprouting of endothelium and then coverage to make new blood vessels. So the way you would maintain integrity and maturity is through extracellular matrix adhesion pathways. In particular, there's the angiopoietin Tie2 pathway, which is the endothelium of vessels. And then lastly, there's going to be an immune environment around this. And really, we didn't know what type of immune environment there would be and what components of the innate and active immune system there would be. But shortly, we'll give you some insight into that. So first, we tackled the angiopoietin Tie2 pathway, and we realized that angiopoietin 1 was important in developing vessel cooption. So if we look at this pathway, Tie2 is found on many things, but is also found on endothelial cells of vessels. And Ang1 and Ang2 compete for that receptor. If there's more Ang1 around, vessel integrity is maintained, and we believe the stabilized vessels allow for vessel cooption to occur. Ang2, if there's more Ang2 around, then there's disruption or destabilization of the vessels, which allows for angiogenic sprouting to occur and new blood vessel growth. So when we looked at this using an inducible knockout mouse for Ang1, when we inserted cancer cells that developed into vessel co-opting metastasis in the liver. In wild-type liver, we got huge bulky disease. When we when we knocked out Ang1 from these livers, or this whole animal actually, we got very little disease, and whatever disease we had was actually angiogenic or desmoplastic. So Ang1 was found to be produced in the hepatocytes, not the cancer cells, and it actually promotes vessel co-option. And if it's absent, the cancer cells will be less active, but when they do grow, they grow as an angiogenic lesion. So we started to progress, and Miran Murata was a postdoc in our labs for the last several years, and he's now become a research associate in our lab. And he's put together a lot of the molecular work that we've done since that time. And he looked at RUNT-related transcription factor 1, or RUNX1, sort of a central starting point for all the other sequential events that occur to promote vessel co-option. And I'm not going to go through all the experiments, but it's interesting that, you know, cells start to communicate in order to develop one pathway of vascularization in this case. So basically, as you have RUNX1 will increase EMT, increase a protein called TSP1, which then goes from the cancer cell and actually binds to a receptor on the hepatocyte and makes the hepatocyte secrete TGF-beta1. TGF-beta1 then goes back to the cancer cell and binds to TGF-beta2, which then promotes an increase in RUNX1 and then continues this. RUNX1 also increases motility of these cells. So all these cancer cells all together lead to vessel co-option. And we've been able to block these processes at 3 different levels using inhibitors. And when we do that, it stops the vessel co-option process. Now, also, remember we said that hepatocytes have to be, we have to be able to move or the cancer cells have to be able to move hepatocytes out of the way in order to co-opt the sinusoids in the liver. And again, I'm not going to go through all the experiments, but basically, again, with RUNX1 being at the center of it, or initiating things, a variety of secreted proteins will then go to the hepatocytes, cause EMT, which increases the motility of these hepatocytes. And some of them, it causes apoptosis in, and leads to the cancer cells having access to the sinusoids, thus vessel co-opting. Now we get into a little bit of the immune side of things, and I resisted getting into the immunotherapy regime just because we just didn't have the expertise in the lab. So we, although Vince Palmieri headed up this work, he then moved on, did his master's and moved on to medical school. It was, we asked Patrick McDonald and his PhD student at the time, Thomas Meyer from Sherbrooke, who are neutrophil experts, to help us with this. We had seen that lysyl oxidase like 4 protein, lysyl 4, was increased in our RNA sequencing of desmoplastic versus replacement in the replacement side. So we were actually looking at this as an extracellular matrix, but we found it being expressed in neutrophils. And there were plenty of neutrophils in the replacement side. So this sort of query into lysyl oxidase like 4 protein actually led us to see that there was an increased number of neutrophils. So then we decided that we needed to explore this properly. So Thomas, finished his PhD in Sherbrooke. We brought him over as a postdoc in our lab to lead this work along with Deanne Kim, who's was working on this project and got a Master's of Science with this. We used a relatively new technology called, I'm blocking right now, but it's a nanostring, I'm sorry. And basically, you can use a large panel of antibodies and apply them to select sites in your histological specimen and keep the spatial orientation. So basically, you first stain the sections that you're interested in, with several markers. Here we did nuclei, CD45, EpCAM, and SMA. And then we look at 12 different sites, hepatocytes far away from the lesion, at the interface, adjacent to the interface on one side and the other. And then we apply a large panel of antibodies. These antibodies have a tag on them, which is a DNA sequence, so that once we apply this to the tissue, if we remove those areas of interest, we can just sequence the DNA, and it'll tell us which type of antibody was present. And that allows us to develop a heat map of a variety of antibodies that were seeking out different antigens, which belong to certain cell types. So neutrophils, macrophages, NK cells, dendritic cells, T cells, Tregs, B cells, and so on. And then after validating them extensively with immunohistochemistry and immunofluorescence, we then are able to kind of figure out what's going on. Just to simplify things, what it appears like is that the adaptive immunity, or the T cell immunity, is present in the desmoplastic or angiogenic lesions, and the innate immunity, macrophages and neutrophils, are highly expressed in the replacement lesions or vessel co-opting lesions. And really, that also tells us that the way we apply immunotherapy is going to be different in these lesions, just as it was for the anti-angiogenic therapy. And so we're quite excited about that. And as I said before, we think that at the end of the day, after several rounds of chemotherapy, that all these lesions become replacement, and therefore they will be highly enriched in macrophages. So when we saw this article here, liver metastasis restrains immunotherapy efficacy via macrophage-mediated T-cell elimination, it made sense to us right away. So basically, they first looked at cohorts of patients that had melanoma and lung cancer that had been enrolled in trials with immunotherapy. Of course, when you enroll people in trials, you actually give them standard of care therapy until it fails. So we were confident that these cohorts of patients here had replacement lesions and had large amounts of macrophages in them. And you could see that if they had liver metastasis, the immunotherapy did not work as well as if they did not, in both the melanoma and in the lung cancer cases. Then they went further and they used a mouse model. They put cancer cells subcutaneously in the mouse, and if they applied immunotherapy, the tumor responded to the immunotherapy. If they had a subcutaneous tumor and a liver metastasis in the mouse, it did not respond to the immunotherapy. If they removed the tumor from the liver and applied immunotherapy again, it responded to the immunotherapy. So clearly the liver was the immunosuppressive agent here, and there had to be a tumor in it to do that. Then they looked at macrophages, and if they cleared the liver metastasis of macrophages, the immunotherapy worked. So clearly the macrophage is the key mechanistic element in immunosuppressing the T cells so that the anti-PD-L1s and other immunotherapies don't work. And then more recently, this summer, a JAMA paper focusing completely on liver, on colon cancer, collected all the patients that had undergone immunotherapy in trials. So again, all of these patients had received all of the standard lines of chemotherapy until they were resistant to it. So that means that they were all replacement and are macrophage enriched. If the patients did not have liver metastasis, they responded a lot better to immunotherapy than if they did. And then one more graph. If the patients had liver metastasis in the past but were resected, they responded better to immunotherapy than the patients that had liver metastasis, but not as well as the patients that never had liver metastasis. So clearly there's something going on here. So in comes Oran, he's an Israeli surgeon who's doing his PhD with us and also will be doing his clinical HPV fellowship with us. And he has already put together a trial that we're starting very soon, where we're going to be using alpha radiation in a special way to these liver metastases to see if we can change the immune profile of these patients and maybe get a better response out of them. And then also he is looking at ways that we can rid the tumor of metastasis and then apply anti-PD-L1 therapy either by ablation, resection, and so on. And that'll be another set of trials. Actually, we just had meetings with Roche to try to flesh that out. This is our last meeting. We love these meetings. Our last LMRN meeting was 2019 in Valencia, hosted by Fernando. And we're looking forward to this year's meeting, which will be the first one since 2019 in Sheffield, early June. I'm really blessed to have a great group of people in the lab who are really keen and as excited about this work as I am. Thank you for your time.
Thank you so much, Peter. Really fascinating work that you're doing, and thanks for walking us through this in a way that can be understood. But congratulations on the story. The evolution, I think, is really very, very interesting to listen to. People can enter their questions in the chat. We don't have too much time, but please do enter your questions in the chat. Peter, when we think of immunotherapy, obviously I'm a cardiologist, I don't know much about oncology. There's a sort of prevailing feeling that immunotherapy is really for a limited number of cancers. So in other words, you have to meet a certain profile. But when I'm looking at what you put out there, sort of your colon cancer and the use of immunotherapy, is it sort of an all-comers kind of thing, or is it really for people who have a certain certain genetic kind of risk or cancer?
Right. Yeah. I mean, there are some things that are obvious. So melanoma it's been a game changer for melanoma, right? So you have people riddled with tumor that kind of disappears for years. The reason for that is it has a very high mutational burden. It's the highest mutational burden tumor that we have. So immunotherapy works really well when you have a lot of different mutations. In colon cancer, it's a specific small group that works right now and has been approved for therapy in those cases. We call them MSI high, microsatellite instability patients, and has been a game changer for that small group of patients. What we're seeing here is we're trying to figure out how to use immunotherapy in a broader sense in more patients. And I think things like deciphering whether, if you add an anti-macrophage plus the anti-PD-L1, are you going to get a better response? Well, it looks like it. So there are trials ongoing right now with these type of agents. And the key to a lot of this is to be able to stratify patients better. So the way taking patients that were metastatic, 20 years ago and thinking they're all the same versus now we've already stratified them for anti-angiogenic therapy. And now we're proceeding to try to stratify them further. So I think we'll see an expansion of immunotherapy in the near future.
Fantastic. That's really encouraging, actually. Terry Alcindor is asking, what is the current role of the so-called liver-directed therapies, and do they have an impact on survival?
Yeah, so liver-directed therapies, I think he's talking about hepatic artery therapies, and the most extensive work that's been done in the area has been done from Sloan Kettering and the Khamenei sisters there. I think they have shown that there is an advantage to applying local regional therapy, both in the neoadjuvant, adjuvant therapy. I don't know that we've seen anything in unresectable cases. Like my sense is that it is better, but I can't prove that. But certainly in the adjuvant setting and in neoadjuvant setting, Sloan Kettering has shown that there is a survival advantage to applying local regional therapy that way.
And why do you think that the liver mets causes a decreased response to immunotherapy? If you had, what's your feeling on that?
Well, we as a transplant surgeon, we know that the liver requires less immunosuppression to survive than kidneys and hearts and so on. And we've always felt that there was an immunosuppressive in a sense, and it kind of has to be, right? Because the first passage of every antigen you swallow is through the liver, through the portal system. So you imagine if it didn't dampen things, what would happen to you? I mean, you every new antigen you see, you'd lose it. It kind of dampens things, and it appears at least one mechanism is the Kupffer cells that are there are activated, and they produce substances that tone down the activity of T cells. So that's one specific mechanism. I'm sure there's others, but that's the one that we're working on now.
And finally, just the last question: how translatable do you think this is to other kind of malignancies? And is there are you collaborating with people who are working on, because obviously we have a big cancer center here at the MUHC, and people working on all sorts of different malignancies. Which way would you go, be outside your area, your abdomen kind of area of specialty? Who do you think could benefit from the kind of work that you're doing?
So we've shown that lung cancers can be vessel cooption or angiogenic. Breast cancer, liver metastases are primarily vessel coopting. We have looked at hepatocellular carcinoma. I mean, that's in my area, but they are also, it's a very unique. It seems that vessel cooption and angiogenesis are coexisting in the same plane in hepatocellular carcinoma, which kind of explains what's going on with using anti-VEGF plus anti-PD-L1 as a combination, and it's working well. So in fact, we think that all tumors can benefit by being stratified this way. And we're pursuing that. We're looking at, we have a variety of partners looking at those different tumor types.
Fantastic, fantastic. It's coming on the hour, Peter. Thank you so much for this really very, very interesting lecture and very comprehensive. And congratulations on all the work that you're doing. It's nice to see this kind of work being done internally here at the MUHC. Thank you so much for being part of our medical grand rounds today. And thanks everyone for joining.
Thank you.
Have a great afternoon. Bye. Bye.